Hello, and thank you for that introduction. So, I'm Andrea Sereda, and I'm a physician who works in London, Ontario, Canada, at the London Intercommunity Health Centre. And here in London, I actually take care of about 2,000 people who are living in homelessness. And because of the street drug scene in Canada, most of those folks are people who use drugs, and many are people who inject fentanyl. So, today I'm going to give you a bit of a fentanyl 101 to deepen your understanding of why fentanyl is creating such devastation in our North American communities, Canada in particular. And then I'm going to update some trends we're seeing in street level fentanyl. I'm also going to give you some data on the Safer Supply program here in London, Ontario, and show you some evidence of our successes. The Safer Supply program here in London is Canada's longest running and largest safe supply program in the country. The work in London started in 2016 out of a desperate attempt to keep people alive. And, at that time, I was just at my wits' end as a doctor. Fentanyl had been in London for about 2 years, and people were dying. And none of the traditional addiction medicine interventions that were available to me were helping people. And that feeling in 2016, that desperation to prevent death, it was felt all over Canada. Here on this slide, you can see that fatal overdose rates have been increasing by double digits in Canada every year we have been measuring. And you probably, even in Scotland, hear a lot about the downtown east side in Vancouver as being the epicenter of these overdose deaths. But here in Ontario, we've actually had the dubious distinction of surpassing British Columbia death rates in 2019, and it's only gotten worse. And right now, really, most of our fatal overdoses are in our rural and northern communities here in Canada. And that has a whole different implication for saving lives. We also know that 3 out of 4 people who have lost their lives to fentanyl in Canada are men, and 88% of those are young men young adults between the age of 20 and 39. In Canada, we lost 44,000 people to World War II. Currently, right now, we've lost 35,000 and counting to fentanyl overdoses. So we're on track to surpass the number of dead we had in the war. And I want to give you a different way of thinking about the numbers in my last slide. Here is a screenshot from a folder in my email inbox I've titled Death Notices. So there's a group in London, Ontario that collects all the information about people that we've lost on the street and collectively sends it out to our group so that we can notify people who were caring for them. So the emails in this email inbox document lives that are lost here on the streets of London. Every single line is a human life lost. And the emails are absolutely relentless. So why have all these Canadians died? The enormous mortality among people using this unregulated street opioid supply is due to the replacement of the street drug supply by fentanyl. We still hear a lot in the media about street drugs being tainted with fentanyl, and that was maybe true at the beginning of the Canadian crisis in 2014 or 2015. But the street supply of opioids in Ontario and in Canada is no longer tainted by fentanyl. It is fentanyl. If people are going out to buy opioids, fentanyl is the primary product that they're going to encounter. And right now in Canada, more than 90% of our opioid overdose deaths are caused by that unregulated street fentanyl. But why is unregulated street fentanyl disproportionately killing people? It's not actually fentanyl that's killing people. We use fentanyl safely in emergency rooms and ICUs and ORs every single day around the world. And it's safe. People don't die. They get a known dose and a known purity of fentanyl, and they walk out of the hospital alive. But what's killing people is the volatility and the unpredictability of that unregulated street supply. And that's because compared to a hospital product, street-based fentanyl is not uniform. It contains many different analogs of fentanyl, which are essentially like cousins that have different potencies with each analog. This slide is good for showing the shifting volatility of the supply. In the right-hand column, you can see all the different types of analogs that could be present in the fentanyl supply. And then on the left with the graph and, the wildly moving colored lines, you can see how quickly this changes. So week to week and day to day, people don't know the strength of their drugs, and that is what is killing people. When I teach my patients about fentanyl, I teach it to them as being like a batch of chocolate chip cookie dough. So if you're not mixing your cookie dough well enough, you can actually end up with a cookie that has 20 chocolate chips or a cookie with two chocolate chips. Two cookies from the same batch, wildly different chocolate potencies. Here you see five samples taken from a single batch of fentanyl that we had here in London about a year ago. And this is a particularly bad batch that was really killing people at a very high rate. So we sent it away for testing. And up here you can see when we sent it away, it was 77% fentanyl. And for reference, here in Ontario, the provincial average for fentanyl is 4 to 9% in a sample. So here we're sitting at, 7, 8, 9 times 10 times the strength of what people are used to. The next four results you see are also from the same sample, and this sample is about half the size of my pinky fingernail. And you can see here, when we tested it, we got pieces that were 0 and 17 and 28% and back to 0. So this is the chocolate chip cookie effect in action. This is why people are dying, the real volatility, the real unpredictability in the fentanyl. And this is not new here in North America. We actually saw the same type of deaths during, alcohol prohibition in the 1920s. The 1920s were a time when people might end up drinking moonshine that was, 11% or 80%. So sometimes people got buzzed, sometimes they went blind, and they didn't know what it was going to be. But here in Ontario, we now have something called the Liquor Control Board. And the LCBO, they really fixed this problem because now you can walk into a store in Ontario and you buy alcohol at a known concentration and a known purity produced under regulated conditions. And so people know what they're getting. Alcohol regulation, it doesn't mean that you won't drink too much. It doesn't mean that you won't fall down and hit your head or develop liver disease from 30 years of drinking. But because the government regulates the concentration and quality of your alcohol, you are significantly less likely to die from poisoning. We're also seeing the presence of benzodiazepines and atypical benzodiazepines in the street supply. It is complicating all of our approaches. Benzos, present an additional risk on top of unregulated fentanyl because they're not responsive to naloxone. And so they create a situation where people can't reverse the sedation, can't reverse the overdose. And, although benzos are unlikely to cause a fatal overdose on their own, what they do is keep people sedated for hours at a time. And so people often are physically assaulted or they're robbed or women can be sexually assaulted. And then also because people are down for a number of hours, often in an unsupervised situation, they can occlude their airway. This leads to respiratory and cardiac arrest. So it really is complicating our approaches in an overdose response. It's also complicating in our approaches and then when we're trying to help people reduce their fentanyl use, because benzos have been in the supply here in Ontario for 3 and 4 or more years at this point. So right now, if people are weaning or withdrawing from fentanyl, they're also withdrawing from benzodiazepines. We're also seeing drugs that are referred to as nitazines. They are another synthetic opioid-like drug. They act very much the same. They're more potent than fentanyl or even carfentanil. And they're slowly increasing in the supply. So we used to see the odd sample with nitazines. Now we're 4%. I believe the checking from just a couple of weeks ago showed nitazines up to 10% in that time period. And then we're also seeing xylazine. And xylazine, similar to the nitazines, is ultra high potency, small amount of our street samples, but increasing. Xylazine we saw hardly ever 6 months ago, and now you can see here we're up to 13%. And here in Canada, xylazine is known as trank dope, and it's getting a lot of attention, at least in our media. And people like this trank dope because it has more of what they call legs. It lasts longer, extends the effects of fentanyl from about 1 hour to several hours. But again, not responsive to naloxone and complicates all of our overdose pictures. And then beyond overdose, fentanyl is also driving an increase in infections of all types among people who use drugs. You can see here in this study that was published in Addiction in 2021 that over 7 years, serious infections grew significantly with that sharp increase in 2015 when fentanyl hit the streets in Canada. And just looking here, you can see an overall 167% increase in the rate of infective endocarditis, which is a heart infection, almost 400% in spinal infections, and then other skin and soft tissue and bone infections as well, all dramatically increasing in that 2014 and 2015. So, what happened in 2014 to make fentanyl start dominating the market and start, people starting to get so sick and get all of these infections? Well, prohibition happened again. So what happened in 2013-14 is the Ontario government, and Ontario is a province in Canada, they took OxyContin from our provincial drug formulary, which meant, virtually overnight, people could no longer get OxyContin. And so in their well-meaning but uninformed action, our government thought if they took these OxyContin pills off the market, people would stop injecting oxy and they'd stop doing drugs. But that didn't happen. And we all know that would not happen. So the government, they took pills of known dose, known purity, made in sanitary conditions at a pharmaceutical factory and erased them. And then the drug market did what the drug market always does. It filled this newly created gap, and it filled it with fentanyl. And then tolerance is increasing exponentially as well. Don't worry too much about the numbers here. The important part here is that people who are using fentanyl, we have seen their use double, triple, quadruple, sometimes go up by, tenfold since the pandemic started. And the reasons for that are very complicated and beyond the time that we have here together. But essentially, like I said, tolerance has really escalated, and that's important for the next slide that I'm going to show you. So why does this potency and why do the number of points of fentanyl people are using matter? So we're going to work through some math. So for the non-clinicians in the audience, doctors take all different kinds of opioids and we convert them to something called morphine equivalents, or MEC. And that's so that we can compare apples with apples instead of apples to oranges. So looking here, 1 point of fentanyl can convert to about 440 MEC. So somebody who takes 1 point of fentanyl is taking the equivalent of 440 milligrams of morphine. And then if we, calculate that based on what the average use is here in Canada, which is, 5 to 20 points of fentanyl a day, and I would say that's even on the low end in this past year, we actually get to people using somewhere from 2,000 to 9,000 milligrams of morphine per day per person. And we have medication, the oxycodone, which we call Percocet in Canada. And if you think about it in terms of Percocet, that's 165 to 656 Percocets every single day per person. And this is where I want you to pause as a group, and you can collectively say to each other, what the fuck at these numbers? Because these numbers are astronomical. Abstinence won't work here. Abstinence will kill people with these tolerances. Withdrawal can kill people with these tolerances. And the approaches to substituting people with alternate opioids, whether it's methadone, Suboxone, or safe supply, is really complicated by this. This slide, and I'm going to show you a few Scotland, but this slide is really why you need to get ahead of this. You need to intervene with your population of people who use drugs. You need to intervene with your street drug supply before you get to these levels. So what is safe supply and how can I help? So the goal for safer supply is to take people who are using that street supply of fentanyl and convert them to a prescribed alternate opioid of known dose and known purity within the setting of primary health care. And, to distill it further, I prescribe pharmaceutical grade opioid pills that people crush and inject so they can reduce or stop injecting their street-based fentanyl. And this is a harm reduction program, so we don't put any expectations of dose weaning or abstinence or, conversion to more typical drugs like methadone on people. We really let people choose what works for them in their own lives and set their own goals. We also don't consider safe supply to be addiction treatment because we don't actually think that most people who use drugs actually need to be medical patients. Most of them don't need a medical intervention. Most people just need access to drugs that won't kill them. And so, without intending to, safer supply, medicalized safer supply, has really become this de facto medicalized model of what drug legalization and regulation could do for people. And that's a perfect segue into why we're successful. So, the data I'm going to show you right now is actually from our first program evaluation, which we published in January of 2022. And we have a second round of evaluation that's almost ready for publication. Hopefully, next month in June, we'll be able to get that out. Won't do any spoiler alerts other than to say our data is even better than this first round. So, what I want you also to know is that this data that I'm going to share is part of a wide evidence base on safer supply that actually exists across the entirety of Canada. And you can access this information on the National Safer Supply Community of Practice website. Things are nicely organized, nicely summarized, and you can look into all the other literature. So, getting back to our program, the important thing that I want you to note on this slide is the retention rate in safe supply, which is 94%. This is really important because in Canada, at least, our methadone retention rates are at best 40 to 50% at 6 months. And buprenorphine, which we call Suboxone, is even less than that, 30 to 40% at 6 months. So this ability of safe supply to engage people and retain people in treatment has been really critical to pulling them away from the fentanyl street supply. And although we firmly operate Safe Supply as a harm reduction program, we also see many improvements in people's health and well-being. We see significant reductions in the amount of fentanyl that people use once they start Safe Supply. Looking at this graph here, the orange bars are representing people who are injecting fentanyl, and the blue bars represent people who are smoking fentanyl. So on the left, you can see people reduce their overall injecting and smoking fentanyl once they came into the program. And on the right side of these graphs, you can see that daily injecting and daily smoking also reduced. So I love showing this finding to people because it even surprised us. So again, to put this in context, remember, every single patient that started on Safe Supply, they had the intention of continuing to inject drugs just in a safer way. And yet we see here that 35% of our Safe Supply patients actually stop injecting drugs altogether. They use their safer supply orally. Some people snort, but a large proportion move away from injecting. We've also seen a dramatic reduction in non-fatal reversed overdoses. So on the left here, you can see we've dropped non-fatal overdoses in the last 6 months from 59 to 23%, and then overdoses in the 1 month prior to the evaluation from 33 to 11%, all just by giving people opioids of a known dose. We've reduced emergency department use in the people we serve from 77 down to 45%, and we've brought hospital admissions down from 36 to 11%, and I'll have some more data about that at the end. And 59% of our patients say their physical health has improved since starting Safe Supply, and 53% of folks said their mental health has improved. Then beyond health outcomes, we've also seen a decrease in engagement in criminalized survival activities like petty crime. So looking at this slide, you can see that 86% of our patients engaged in some form of crime before being on Safer Supply, which was almost always to pay for their drugs. But a full 44% of those people have stopped all criminal activities once they have a prescription for Safer Supply. And then another 47% say that they have reduced. And this is because, people don't have to commit crime to pay for their fentanyl anymore. So here in Ontario, a point of fentanyl costs anywhere from $20 to $40. And again, if you do the math, if people are using an average of, 5, 10, 20 or more points of fentanyl every day, that could mean they need to make $200, $400, $600, $800 a day just to keep themselves from going into withdrawal and being horribly dope sick. But when we prescribe their opioids, people no longer have that financial pressure to stay out of withdrawal. And this is reflected in our data around incarceration as well. You can see here that less than half of our patients who were previously involved with police still have contact with police after starting Safer Supply. We've also seen reductions in the number of women performing sex work. And again, this is because women no longer need to work to make hundreds of dollars per day to pay for their street drugs. So again, remembering back to, our criminalized activity slide, people need to make that $200, $400, $600 a day to stay out of withdrawal. And street level sex work in Ontario, at least in London, Ontario, the going price is about $10 to $20 per sex act. And this is where I want you to do some mental math for these women. And I'm going to be purposely crude because I really want you to really feel the impacts on these women. When you compare the price of a blowjob in London at $10 to the money these women need to stay, per day to stay out of withdrawal, which is that $200, $400. That is a lot of blowjobs behind dumpsters for these women, day in and day out and day in and day out. And our program, we will firmly and loudly say here that, sex work is real work, and we're not trying to save any women from sex work. But what we have been able to do is we've been able to help women engage in sex work at a pace that they choose. So we've given them their choice back. This woman says, we don't have to go to the streets anymore to make our habit, to make money to pay for our pills. Since I've been on the program, I haven't gone to jail in 3.5 years, so that's a good thing. I'm pretty much not working in sex work at all anymore, so it saved my life. Just a little bit more research, 3 more slides, and then we'll sum up here. So this is a study our group published in CMAJ, the Canadian Medical Association Journal, this past September 2022. So for this study, we looked at administrative health data, so data that the government collected on people's health service use. And we can do this because we have a health card that everybody in the province and the country uses, so we can track those interactions. And what we looked at it for primary outcomes were emergency department visits, hospital admissions, and then admissions for infections, and then the costs of all of that. And when we looked at people's health service utilization in the year before them being on safe supply and then compared it to the year after them being on safe supply, we saw emergency room visits, inpatient hospitalizations for infections among people getting a safer supply go down significantly, almost 50% in all categories in that year following their program entry. And then, in our matched controls and unexposed individuals who did not have a safer supply, there was no change in these outcomes. Specifically, I want to highlight here as well that infections in people on safe supply decreased by 50%. And this reduction in service use translated to overall reduced healthcare costs in the order of about 50% cost reduction per person. So when we did this study, it was 82 folks in safer supply, and we showed that it was saving our local hospital system millions of dollars every single year. Here in London, Ontario, we know there's about 6,000 people who inject drugs. So if 82 people are costing the hospital system millions, what is 6,000 people costing? And really, what is the burden and cost to the Ontario healthcare system due to prohibition and fentanyl? So we hear a lot about meeting people where they're at in this work in harm reduction. And as you contemplate what we've talked about today, I want you to remember that meeting people where they're at, it doesn't just mean putting on a backpack and going down to an encampment, although we do that too. Meeting people where they're at also means treating people as experts in their own lives, meeting them around their own cultural and social context. And it really means, at least to me and to our program, as treating people as colleagues and equals. And so safer supply prescribers, we stand on the shoulders of brave drug user activists who have actually pioneered harm reduction in this country. And safer supply has grown and is succeeding because those drug users are our equals and they have an equal voice at the table. And we consider their expertise just as valuable as our own and quite often more valuable. I want everyone here to reflect on the fact that everything we currently take for granted in harm reduction in Canada was once illegal. I want you to remember that needle exchanges were illegal here in the 1980s when people were trying to save their friends from HIV. Safe injection sites are becoming more common in Canada, but up until 2008, drug users were risking their own legal freedoms by operating these underground safe injection sites to save the lives of their friends. In Canada, naloxone is on every street corner these days. But harm reduction activists, even just 10 years ago, had to beg and borrow and steal naloxone, before the government provided it. And so safe supply is the same. Safe supply has been on the lips of drug user activists in Canada for years before the medical profession, our team, discovered what it was. And so we're really learning from the expertise of these activists, and we're really using their guidance to make this program better and stronger. And we're also focusing on the fact that safer supply is about so much more than drugs. It's about building relationships with people who have been pushed to the margins. It's about ensuring medical professionals actually provide comprehensive care to people who use drugs. It's about generating the evidence for a government to recognize and rescind those laws that are criminalizing drug use and drug users. In Canada, we need to take steps to actually get ahead of this fentanyl crisis by expanding all models of safe supply. We need to get ahead of this instead of always being 10 steps and tens of thousands of bodies behind. So I really implore Scotland, please don't let it get to the level that it is here in Canada, that it is in the United States. Please take action now. Please intervene before fentanyl dominates your streets and you find yourself in the situation that we find ourselves today in Canada. Thank you for coming to listen to me today. I'm not here in person to answer questions, but if there are questions, then your program organizers can help you get in contact with me. Thank you so much.